Well, Shannon, thanks for starting out on this thing, because there's no roadmap on this, and that's exactly, I think, where we needed to be from that type of thing, because I think it gets many of you in the audience to understand where some of these young scientists are coming from. What we're going to do is we're going to continue on with each one doing theirs. I have a group of expert panelists down here. They're going to potentially ask questions, or they don't ask questions. I'm going to have the scientists, the young scientists themselves, ask questions of this panel, so you can see a dialogue. The next person is Fariba Donovan, and is coming to talk on determining the impact of biological response modifiers on Coccidiomycosis severity.
Thank you so much for having me here, and I greatly appreciate the opportunity to talk about my research. I'm a little bit further along on those challenges, so I'm going to pass on that. I have to summarize many years, so I will just skip that and go to the research we are doing here at Valley Fever Center for Excellence at the University of Arizona. Very fortunate to be part of the team with John Galgiani and the rest of our team. Oh, great. So just briefly, I wanted to bring you up to date with the valley fever. I know most of you know about the disease, but very quickly, this is a disease that is caused by fungus, which is in soil, and we are endemic for this in Arizona as well as California. 2 strains of cocci are there, Coccidioidomycosis and Posodacea, and we like to call it cocci versus Coccidioidomycosis. At least about 150,000 cases, and it can be caused by only single fungus. Usually the disease is asymptomatic, 60% of cases. Mild cases about 30% of time, but about 10% can be very complicated, and out of those 3% become disseminated. Not that we only focus on this group, but that's one of the major groups that we work on. The good news is that when you have the infection, after the infection, you develop lifelong immunity. Very briefly, I show you the life cycle. The dry soil in Arizona as well as California harbors the mycelium, and then the arthroconidia separates. You see here the area that is endemic for it, and Thomas here, the map has actually been expanded to many more areas, but you see that we are endemic as well as San Joaquin Valley. Once you inhale this arthroconidia, you develop fungal pneumonia, and one of these arthroconidia can become a spheroid with about 300 endospore that can go through the same cycle. Now, on the other hand, I want to bring you up to date with biologics. They obviously, as you know, modify and interact with host immunity. They dampen the immune system or immune response, and because of that, they can be used for diseases such as rheumatoid arthritis, psoriasis, or inflammatory bowel disease. And they target a million things. Amongst those are the one that I have here, including TNF-alpha. So what we know is that the risk of disseminated cocci, can be going up to almost 150-folds in patients who are immunocompromised. In our lab, Dr. Shubitz actually in 2021 published a study that is TNF-alpha knockout mice is more susceptible to cocci. This is the study that is actually here shows that TNF-alpha knockout mice versus B6 mice, they both got inoculated with 50 spore of 1038, which is, although virulent, but slightly slower virulence than normal strain of cocci. And you see the clear difference between survival in the 2 strains. Conclusion is that TNF is important. So my question here is on the human side. That's what I do. I see patients with cocci all the time. Some of these patients, when they are on biologics, they develop dissemination. Not everybody. So my question is, which group is safe, which group is not. The clinical question is ultimately how safe these medications are and can we use them in general. The objective of the study is to find the incidence of cocci in patients with autoimmune disease who are on biologics, evaluate the frequency of various cocci presentation when these patients are on biologics. And then, of course, we need IDSA guideline to tell us what to do when these patients come to us. So our ultimate goal is to update these guidelines. Our study was a retrospective cohort study. EMR, as we mentioned earlier, electronic medical records, were reviewed using the ICD codes for these diseases. These are patients who are more than 18 years, and the study span was about 2 years. We extracted many things in the charts, as you see here. Since my time is limited, I'm going to go through this very quickly. This is the study model that we had. We had about 1,000 charts or electronic medical records that had both cocci as well as autoimmune disease ICD codes. Ultimately, we ended up having about 587 with confirmed cocci, and out of those, 138 with combination and 449 only with cocci. When we look at the data, cocci was diagnosed in more in male, very similar to previously published. A median length of residence in Arizona was about 16 years, again similar to previously published studies. Patients that had both cocci and autoimmune disease, though, they were older and they were female in compared to those that did not have autoimmune disease. So, of course, this is corresponding to the rheumatology literature. They are usually older, more female are getting this autoimmune disease. And interestingly, these patients had shorter Arizona residence. I think what happens is these patients come to our area, they are already sick, they seek medical attention, they get screened for being started on biologics, thereby they get a screen for cocci as well. So we diagnose this sooner. So our study showed that if you compare pulmonary cocci versus disseminated cocci, African Americans disproportionately had more dissemination. Again, very, very corresponding to the previous publication. Interestingly here, when you compare cocci patients with autoimmune versus those without autoimmune disease, no significant difference between different clinical presentation, including dissemination. So conclusion is autoimmune disease by themselves don't affect the presentation of cocci. Now, when you look at, these are the confirmed autoimmune patients, and as you see here, most of them were rheumatoid arthritis. These are the patient population I'm focusing on, for now at least. When you look at the risk of dissemination of the disease in patients who have autoimmune disease and go on biologic, people who are on biologic have higher risk of dissemination, 34% versus 14%, statistically significant. So the conclusion, and I'm going to skip this, this is only showing you that the providers, clinicians, when they see the cocci diagnosis, pretty much majority, I would say, or 100% of these people come off of biologics, irrespective of if they have dissemination or not. So the question is that a good practice or not? Now, the conclusion of our study was that confirmed cocci led to the discontinuation of biologics. Also, autoimmune disease do not increase the risk of cocci, and biologics significantly increased the risk of dissemination. The very last thing that I wanted to talk to you about here is the future direction I have for our study. The prospective studies needs to be done, and we are actually in the process of starting that, to answer this question, how safe is this to use biologics in our endemic region for cocci? And to answer that question, my hypothesis is that if we have adaptive immunity to cocci in our area, that means you have been living in Arizona for many years, in case that patient needs to go on biologic, we think actually you don't develop as severe of the disease. To confirm that, actually to identify this group of people who are at lesser risk potentially, this is a preliminary study actually. I think they put my older version of my slides, unfortunately. That's okay, I can talk about this just. Here we go. So what I did here was that we had several donors who knew they were positive for Cocci. We isolated their PBMCs, and we actually stimulate that with Coccidiophyrial lysate, the crude extract of Coccidiophyrial at different concentration. As the concentration goes up, that actually interferon gamma response in these patients who have positive history goes up. So I think, as Dr. Ample has done this experiment before, we can use that interferon gamma response or CD25 on CD4 expression response as a marker for people who are having immunity, and then compare that group with people who do not have the immunity, and then prospectively follow these patients who go on biologics and compare the level of the severity of the disease in this population. And I really appreciate your time. Thank you for the opportunity.